Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here at the AusACPDM conference in Cairns, Australia, to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based.
Welcome back to the Research Works podcast desk at AusACPDM. We are joined by, I think we can now safely call her friend of the pod,
100%.
Dr. Sarah Reedman. Welcome, Sarah.
Thank you. I'm so excited to be here.
We're excited to have you back. You and Dana got to have a conversation at EACD in Bruges, which was really interesting, and I loved listening to that and hearing your thoughts. And I thought, given that, you both wear clinician hats, you both wear research hats, you both wear clinical research hats, now would be a great time to have a conversation about the state of the evidence in clinical care. And I'd love to get your thoughts on that, both of you, as expert clinicians in this area.
Yeah, go for it. You go, Sarah.
All right, you've given me the floor.
Yeah.
Great prompt there. I think there's something to be said for integrating research directly into clinical practice and what it means to be a clinician researcher.
Yeah.
So we have lots of evidence, and actually the Australian Academy of Health and Medical Sciences integrated and synthesised all of that evidence into a review report at the end of 2022, looking at the state of clinical research, in Australia.
Yeah.
And one of the core recommendations, visions, I suppose, that came out of that report was research as a core function of the health system in Australia. So it's not an add-on, it's not a luxury. Research and innovation are core pillars and core functions of the healthcare system in Australia and obviously in the world.
Yeah.
And I think that's an important thing to have in mind. But I'd like to talk about why that is and why we should be doing
Good
that.
question. Yeah.
I love that.
Can I just say from that, that's a great way to open, Sarah, because it's so true. Like within healthcare, we have, let's look at the current landscape within Australia. The National Disability Insurance Scheme now has been around, as we heard yesterday, 10 years, which stunned me. It always feels like it's new, but it's 10 years.
Yeah.
And what we've seen over that time is, I guess in a little way, it does feel a bit fragmented in services in that there's a lot of different providers. Offers great choice for sure. And I think, services like the one I'm part of wouldn't be around unless we had something like the NDIS. So it's absolutely beautiful. And what that does mean, though, is that there is a lot of different kinds of service providers operating within Australia. And when you think about then the resource that will be required to evaluate how your practice is actually doing, because when you're part of a hospital, it almost is quite instinctive, right? Outcomes are measured, you have to report on them.
Yeah, and it's something that's encouraged from a professional development sector as well. There's continuous quality improvement. There's research if your department has an integrated research arm to it. There's always opportunity for that.
And it's it's just opened it up and shifted it so that there's more opportunity that is out there at the moment, but also requires a lot of additional effort to look at how you're actually going to do that. And I guess to start off, the answer of the why is kind of like, why not? But also, like, we should, as health professionals, we need to constantly be evaluating how well we're doing.
Yeah.
And
absolutely.
that's I don't know, a first place to start? I don't know, where do you want to go with that one, Sarah? What do you think?
It's a good point. I think one thing that many of us, if we think back to our uni days, we would all remember that we actually had to go through our professional code of conduct. So if you're a registered health practitioner in Australia, for example, we've got a code of conduct as an AHPRA, under AHPRA. And part of that, there are actually some really core things that all of us have a responsibility to do. To practice safely, to practice ethically, and actually to use healthcare resources judiciously. I feel like in the context of the NDIS, which has been so transformative, the single most transformative thing that has happened in the disability landscape, I feel like we need a refresher on that. We need to actually go back to our core principles literally to our foundation documents and the things that we all have a responsibility to do, and reflect on, are we actually living up to those, and are we fulfilling those responsibilities? Like, to take an example, this is just a de-identified contextual example. I follow a lot of social media pages that are kind of professional groups for physiotherapists, occupational therapists. And there was a question, and a really well-intentioned question about from probably like a regional or rural practitioner working with a young person with cerebral palsy in GMFCS level 5. And the question was, I currently see this little young person, who's 5 years old, twice a week, but they have the funding to be seen 3 times a week. Should I do that? And it was a really well-intentioned question. And it was, there was also behind that, obviously, wanting to meet the family's goals and needs. But is that a judicious use of healthcare funding and limited resources that we all have to share? And I have to keep that in the back of my mind. And research is always working towards that. It's always helping us understand what are the most effective and cost-effective ways to help solve critical problems that we face.
And there's different levels to that, right? So sometimes when we talk about research being integrated into practice, it doesn't mean you need to do a clinical trial. It doesn't mean you need to do an RCT.
No.
It often means, well, let's just start with, let's make sure that we know what the current evidence base is and apply that. And research, keeping up to date with the research is one of the things, that's why we do this podcast. But it helps us to stay in tune with what we know is going to be the most likely to improve outcomes, and therefore a better use of time, and hopefully then a better use of resources. And they're all just incredibly related, but it's that research mentality that makes you go, okay, what is the best thing out there, and can I measure the outcomes as a result? And keep us, I guess, accountable to a way of what are we doing this for and to what end?
And
absolutely.
I think when you talk about research, some people hear research, they find that word quite daunting, I think, but it comes back to what you were saying earlier, Sarah, evaluating your service, evaluating what you're doing, and what you're saying is evaluating that against what we know to be the best available evidence for what works.
Absolutely.
And it's that core, I love how you brought it back to our sort of code of conduct. What have we signed up for here?
That's right,
And, it's so important. Let's talk about safety. You and I spoke about safety at EACD, and safety isn't always just about, making sure the child doesn't hurt themselves physically. We're also talking about emotionally as well, aren't we? It's just as important.
And we've heard some great presentations throughout this conference. Actually, the keynote by Hannah Divany that you obviously had a great role in facilitating. What brought me back again to that idea of disability being a lifelong experience and how important it is to have really positive healthcare experiences. Also a fantastic presentation by Dr. Jackie Barfoot, who was talking about parent-child interaction. And one of the things that she was talking about was kind of attachment and relationships, and she brought up some great evidence around how we have shown that when there is an increased parent-child attunement and a really strong attachment, and parents have a higher level of responsiveness, that actually is related to improved gains in therapy and the increased developmental progress. So there is actually evidence to support this approach. We knew that already. We talked about that. It was a good refresher. It was a good refresher.
Isn't it? It's that whole relationship, and we've heard about that a lot within this conference, is how vital that relationship. We're not just talking about motor outcomes here. We're talking about cognition. We're talking about communication, and zooming out a little bit more as well, it's not just the ICF, it's human rights. And when you look at it from a human rights perspective, there's an urgency about it. It becomes even more important that we are following these principles of what we're doing as health professionals in our industry.
Absolutely.
And, I'm just coming back to something else you said earlier, Sarah, about using health resources judiciously, and that the first thing I think of when I hear that is, not doing therapy for the sake of getting good at doing therapy. You know, we want our kids to be engaged in therapy so that they can go and live their lives.
Yes.
And so the way that we can maximize time spent in therapy is, again, by following the evidence base, right?
Yeah, absolutely.
Yeah.
So just for those who, are new to the podcast or might need a little refresher, when we talk about the evidence base, what do we know as those kind of core principles of evidence-based therapy?
We have, let me, put my hat on. Dr. Michelle Jackman, led a great paper looking at functional therapy. And so I guess obviously there are lots of different types of therapy, but functional therapy is probably a core, goal-directed functional training. It's a core element of what we typically do, particularly with children with neurodisability and cerebral palsy. And it's things like setting really good collaborative goals, practicing the task that the goal is related to, doing things in as much as possible a natural environment or working towards that or ensuring that that's a part of the therapy program.
Yes.
Making sure that the child is really active in what they're doing, so that they're doing child-initiated activity, that we're using the properties of the task and the environment and the materials that we're working with to elicit the way that a child responds to those so that they're doing the problem solving.
Yeah.
Those are really all of the key ingredients, as well as obviously being really highly motivated, being fun. So we know all of these things.
We know that.
We
Pretty
know
well consolidated knowledge.
Yeah, absolutely.
Yeah.
I think I've seen some concerning stuff online where it's a therapy and it's claiming to be things that it's not.
Yes.
So, for example, therapy saying this is bimanual therapy, this is constraint-induced movement therapy, when actually those things have special definitions. They have their own characteristics and key ingredients and protocols. For example, bimanual therapy being a goal-directed training program whereby you're aiming to improve the ability of two hands working together by practicing those things. So by practicing bimanual tasks where the two hands are coordinating together to achieve a functional goal. That is the only type of thing that bimanual therapy is. It's not anything else. And same with constraint-induced movement therapy. It always involves the use of a restraint. And you can't call something constraint-induced movement therapy if it doesn't have that. So I think we need to be really careful about those things. When we're talking about different types of therapy, and because those are the things that comes from amazing clinical research that's been completed of really high quality, embedded in the practice context, done by clinician researchers, safe in a safe and effective way.
I guess from there, I know what you're referring to when people are sort of defining, and you read it and go, no.
Kind of using it as a buzzword rather than its actual definition.
And I guess I can hear from the other side of go, what's the danger in that? Why is that harmful? I think that's worthwhile talking about, because I often hear people say, oh, look, this is task specific. And I look at it and go, but I don't know what task you're doing. I don't think that's task specific. And in my mind, I just go, well, if you're saying it's task specific and all these things, basically the evidence-based buzzwords of what we know works, I think you're diluting something where we know that we can get a certain outcome for. And I think that affects expectations. And it definitely affects the fidelity of interventions as well. But it goes beyond that, Sarah. I feel like there's more to it there as well, isn't there?
Yeah, absolutely. I think it's really important that we, we also don't overpromise and underdeliver. We have a strong evidence base for a lot of interventions, but you have to remember that the efficacy of an intervention. So when I say efficacy, I mean how well it works to achieve a certain outcome. A large part of that is related to core ingredients of that intervention that you can't modify, because if you do modify those parts of the intervention, we don't actually know if it's as effective anymore.
It becomes something different.
It becomes something different, exactly.
Yeah.
Which, of course, you could research that and you could
but
find
there's a whole
out.
process for that,
Absolutely.
right? You can't just
And
tweak it.
Absolutely. And so we need to. You talked in a presentation about fidelity. We need to monitor our fidelity to these interventions on a continuous basis to make sure that we're not straying from what those core ingredients are that actually that we know is part of the efficacy of that intervention. And bringing that all back to the beginning of this discussion. The organisations and the people and the clinicians that are doing that well are the ones that are integrating research into clinical practice. They're the ones who are monitoring the quality of what they're doing, they're monitoring the fidelity of what they're doing, and they're innovating on top of that. So bringing it further forward. So that's why that model of practice is so crucial to our continued progress in the field. Absolutely.
And just to add to that, Sarah, I think the other component on top of that is the kind of de-implementation of stuff that isn't working once there's evidence to show that it's not working anymore. The beautiful thing about research is that our evidence is constantly evolving, and the more we learn, the more questions we ask, and we answer those questions and we get more information. It's a beautiful feedback loop.
Yes.
But I think it's quite challenging to keep on top of that, if for the centres who are doing a really good job of it, but particularly for the ones who perhaps haven't integrated research into their clinical care as others have. Can you just talk to that a little bit?
Yeah. It's interesting because I feel like de-implementation is probably even hard. Like, implementation is hard.
Yeah.
De-implementation is even harder.
Yes.
It's really hard to let go of something that you perhaps fundamentally believe in, if you've been using it for a long time. Obviously part of our responsibility as health practitioners is to be aware of what new evidence is out there. I also reflect upon our role as researchers in guiding people through that process. And I think there's probably more, honestly, there's more that we could do in assisting de-implementation of practices that don't work. And also, trying to shift that. One thing that I was thinking about, I've did some presentations about Habiteal, which is now, nearly that whole stream was about Habiteal. Right? So we obviously now have a really big volume of research there to support that intervention. In Australia, there is only one place that Habiteal is offered, and that's where I'm lucky to work at Cerebral Palsy Alliance at Alambi, and we have 8 clients who can access that every 6 months. And I think it's incumbent upon us to actually try to implement that into practice better. And so I'm always thinking about that. I'm aware of that. But at the same time, it has to be done the right way. And the reason why we haven't rushed into it is because we wanted to be absolutely sure that this is what we should be doing. And we also wanted to know, who does this benefit the most and how much, so that we can effectively communicate that, and it can help families and clinicians make a decision about how to use their resources judiciously, their limited resources. And we've done that now, and now it's time to start the work in implementing that.
It's almost like a bigger part of the work, isn't it? It's that communication side. And we touched on a little bit about social media, and we've talked about it a few times in the podcast already these last few days. And social media is such a powerful tool.
Emotive tool.
Very emotive. The number of followers can sometimes seem like evidence. And we've got to be so careful not to confuse the two, because Wade Schrader talked about it so beautifully. He's like, what standard are they held to? And as clinicians, as health professionals, under our code of conduct, actually we're held to a higher standard. So if you're looking at an intervention, wondering whether to be a part of it, from a clinician's perspective, you need to look at those ingredients, because you can call things bright and shiny things, and it might be new or whatever it might be, but do those ingredients actually match up with what we're saying works? And it's that self-reflection that's actually really crucial.
And I often come back to our talk with Dr. Jessica Stokes-Parrish and the CRABS
such a good
framework.
One.
And, I think it's just as important. We talk about that in terms of evaluating social media content for families, but I think also for clinicians as well. Like that's a really powerful kind of acronym and framework to be able to use to consider thoughtfully what you're seeing online.
Yeah, that's right. How we actually evaluate it.
Yeah.
And we've seen a lot of stuff on social media.
Yeah. It's a powerful tool. It's a powerful tool, and it helps, and it's, you know, it does a lot of good. And I think maybe it has the power to continue to do a lot of good.
Yeah.
It's just, you know, putting your reflective hat on and thinking critically about the type of content that you consume, whether you're a clinician or a family or a researcher.
Yeah. And I feel like already even just talking about it this way as well, you know, if you're a clinician, you know, it is actually our responsibility to be evidence-based. And it doesn't matter where it is that you work, you know, being able to evaluate what it is that you're doing is part of our job and it's part of our responsibility. Yeah. And if you are sort of working on your own, you don't have as many colleagues around you, there's great networks around that you can get, you know, like these conferences are incredible. You can meet so many people and talk to them as well. But any other tips and pearls of wisdom, Sarah, of what therapists can do? Because, like where can they go for more support or what courses?
It's a good point. The one thing I would say is that perhaps we're lacking maybe a mechanism for really small practices or sole traders to get engaged in some work to help them with innovation, research and quality improvement activities. I think our associations, obviously professional associations and, you know, the Australasian Academy and Cerebral Palsy and Developmental Medicine are really good networks. But I'd actually like to see some advocacy in that area, to be honest. I think that's probably, if I could say one thing, it would be let's try and find a way that we can build capability in that area so people don't feel like they're swimming in an ocean, you know, without a lifeboat.
That's a really good point. Yeah.
Well, that was a good conversation. I enjoyed that.
Yeah. You guys aren't busy. You could do something like that, right? In all your spare time.
I was just talking to Brian Hoare about it, and he was like, you know, maybe we need like a union or something for like, you know, like smaller practitioners to be able to come together. And I was like, oh, yeah. Someone can do that.
Okay, the idea is out in the ether. Let's just see what comes back.
Well, other people are thinking about it.
Yeah. I know. It does seem to be a bit of a common theme, and just talking to a few people, it just seems so relevant. And look, at the end of the day, we all have great intentions. We want to help the kids that we work with. But it's matching it up with our responsibilities and being true to that, and being evidence-based is currently, you know, it's the way forward, and it's how we can use funds ethically, because they're public funds. And we need to use them ethically.
Absolutely. Yep. Couldn't agree more.
Yeah.
Great point. Well made.
Thanks.
As always.
It was good to have the conversation. Thanks, Sarah, for joining.
Thank you, Sarah.
Being part of the conversation. It's so great.
So good.
I'm sure we'll talk to you at the next conference. Should we just do that?
Anytime.
Anytime. Well, thanks everyone for listening, and thanks for being interested in all the things that we're doing at AusACPDM as well. It's been so much fun sharing this series
it really
with everyone.
Has.
Yeah. All right. We'll talk to you all again really soon. A few more to come still, so stay tuned. Bye.
Bye.